Status epilepticus is a hyperacute neurological emergency. While a typical seizure self-terminates, in status epilepticus, the brain's electrical activity becomes trapped in a continuous destructive feedback loop. It's continuous seizure activity lasting 5 minutes or 2 seizures without regaining consciousness. Beyond this 5-minute threshold, spontaneous termination drops and neuronal damage risk increases. This is caused by synaptic changes. Inhibitory GABA receptors retreat, while excitatory NMDA receptors multiply on the cell surface. Time dictates the physical structure of the brain during an event. This receptor shift creates a progressive physical resistance to primary rescue medications. Between 0 and 5 minutes, mechanical interventions must happen simultaneously. This involves securing airway patency, applying 100% oxygen, and establishing 2 large-bore IV catheters. A bedside glucose check is required immediately. Metabolic derangement is a primary and easily reversible trigger for continuous seizures. If glucose is below 60 milligrams per deciliter, the correction sequence is exact. Administer 100 milligrams of IV thiamine before pushing 50 milliliters of 50% dextrose. This matrix outlines first-line pharmacotherapy. Intravenous lorazepam at 0.1 milligrams per kilogram is the preferred agent for rapid seizure termination. If IV access is unavailable, the immediate alternative is intramuscular midazolam at 0.2 milligrams per kilogram due to highly effective muscle absorption. Diagnostic neuroimaging must never delay the administration of these initial doses. Seizure control is the priority. Initial control relies on overwhelming the central nervous system with inhibitory agents before pharmacoresistance can mature at the synaptic level. If clinical seizures persist past the 5-minute mark despite adequate benzodiazepine administration, the protocol dictates an immediate escalation to step 2. Looking at this chart of maximum safe infusion rates, the goal of second-line therapy is to rapidly achieve high serum concentrations of longer-acting anti-epileptic drugs. Phosphonephrine is preferred over traditional phenytoin because it allows for a faster infusion rate and is compatible with normal saline. Levetiracetam is a highly advantageous alternative. It can be fully infused in 15 minutes, carries minimal drug interactions, and requires no continuous cardiac monitoring. Step 2 is a race to saturate functional receptors before the patient reaches the threshold of refractory status. Seizure activity that continues at the 20-minute mark, despite appropriate first and second-line dosing, is classified as refractory status epilepticus. Entering Step 3 requires a transition to critical care resources. The patient requires endotracheal intubation, central line placement, and continuous arterial blood pressure monitoring. For intubation induction, propofol or midazolam are preferred, paired with rocuronium as the paralytic agent. Succinylcholine is contraindicated. The preceding 20 minutes of motor activity can cause muscle breakdown, meaning succinylcholine administration carries a risk of fatal hyperkalemia from rhabdomyolysis. Paralyzing the patient eliminates visible motor convulsions, but it does nothing to stop the electrical activity in the brain. This is non-convulsive status epilepticus. Despite the patient appearing perfectly still, the ongoing electrical activity continues to cause neuronal death. Because of this, continuous EEG monitoring is mandatory whenever a paralyzed or anesthetized patient fails to emerge as expected. Trusting the absence of a physical convulsion is a lethal trap. Without an EEG, clinicians cannot see the ongoing destruction of brain tissue. Suppressing refractory seizures requires continuous anesthetic infusions. Propofol is frequently used for its rapid titranability and quick awakening profile. However, propofol has limits. Doses exceeding 80 micrograms per kilogram per minute or durations past 48 hours carry the risk of propofol infusion syndrome. This requires daily monitoring of lactate, creatinine kinase, and triglycerides. Early administration of ketamine is an increasingly recognized alternative for refractory status. As an NMDA antagonist, ketamine bypasses the down-regulated GABA receptors that have rendered standard rescue drugs useless. Ketamine maintains hemodynamic stability and preserves respiratory drive, all without increasing intracranial pressure. This simulated EEG trace demonstrates the therapeutic endpoint. We aim for complete seizure suppression or a targeted burst suppression pattern with an interburst interval of 2 to 10 seconds, maintained for 24 to 48 hours. Refractory management is an act of controlled chemical coma. It requires constant vigilance to ensure the anesthetic does not become more toxic than the seizure. If seizures continue or recur more than 24 hours after initiating anesthetic therapy, the diagnosis is super-refractory status epilepticus. The initial strategy is to optimize combined anesthetic regimens. If a ketamine infusion has not yet been started, it should be initiated immediately. Megadose phenobarbital can be used to depress cortical activity, requiring high target serum levels of 40 to 60 micrograms per milliliter. Specialized salvage modalities include high-dose immunotherapy for suspected autoimmune etiologies and targeted hypothermia to slow cerebral metabolism. This super-refractory state represents the failure of standard pharmacology, forcing clinicians to alter the baseline thermodynamics and immune state of the brain to break the cycle. The surgical environment carries unique vulnerabilities. Prolonged fasting leads to subtherapeutic home antiepileptic levels, while complex anesthetic drug interactions can lower the seizure threshold. One of the most critical triggers in the perioperative setting is local anesthetic systemic toxicity, or LAST. Seizures from local anesthetic toxicity require immediate 20